Yeah.
الصوت عندنا شغال.
بسم الله الرحمن الرحيم. الحمد لله رب العالمين والصلاة والسلام على أشرف الأنبياء سيدنا محمد وعلى آله وصحبه أجمعين. I'd like to welcome you all for our third Western Region SASMBS Bariatric Club for the year 2024. We have the great honor. سيدنا محمد وعلى آله وصحبه أجمعين.
Yeah.
We have the great honor today to have our colleagues from gynecology, Dr. Fahd Gracie and Dr. Hussein Saban, who will share us with their knowledge. First of all, I'd like to welcome our great moderators, Dr. Mahmoud Hamou, who is a senior bariatric and neurosurgery consultant at Park Hospital. Dr. Abdullah Sindi, senior consultant general and bariatric surgery, also one of the experts in the field of bariatric in Western and Eastern. I'll give them the microphone to start the meeting. Our meeting will be about polycystic ovary, fertility, and the role of bariatric surgery.
السلام عليكم ورحمة الله. بسم الله الرحمن الرحيم. نفتتح هذا الاجتماع. حيكون first speaker دكتور فهد الجريسي consultant of urogynecology and reconstruction surgery, assistant professor in Jeddah University. He graduated from Canada. I think it was very one. He will talk about relationship between polycystic ovary disease and obesity. As you know, this is very important topics and we face it in bariatric surgery and gynecology.
ما جابوا. بس sliding slides كده. طيب لا خلاص انا اجلس هنا.
السلام عليكم ورحمة الله وبركاته. Good evening, everybody. الله يعطيكم العافية. It's a great honor صراحة to meet the colleagues, meet the senior doctors who's having a good relationship with the urogynecology and gynecology. دكتور حمو والجميع حياكم الله. دائما نسمع عن الناس ما شاء الله البرياتريك they're doing a great job. يعني ضمن دكتور عادل أنا قابلته كم مرة يعني أنا كنت كبير في العمر طبعا بس وقتها كنت جونيور لسه انت وهو كان ما شاء الله بيشتغل برياتريك وبيجي الحرس وبيشوفه وانا وعلي. التشالنج بدأ بصراحه من ناحيه البرياتريك and polycystic ovary since we came back في العياده الجينيكولوجي. فكان دكتور علي بيجي يكلمني يقول لي فهد what's going on with these people اللي عندهم PCO? What's wrong? And we're doing sleep and doesn't work. The reduced weight 10 kilos 15 kilos they're happy after 6 months. they gain the weight back. Did you change something? No. Did you change your lifestyle? No, it's the same lifestyle, but I'm gaining weight, I'm not losing weight. But honestly, like it's a big obstacle for even a gynecologist about the polycystic ovary. It's really hit everywhere. Hitting with obesity, hitting with infertility, hitting with the metabolic diseases and syndrome. So it's really pain in the neck to treat this disease. We'll see what's going on and how obesity will affect. So when the woman, especially here in Saudi Arabia, they have the chance of having a polycystic ovary about 20 to 25%. If you go to the North America, you will not find it that much. But especially in like North Asia and Saudi Arabia, it's too much. We have like 25%. And guess what? We've seen them, like 90% of them, they will be obese already when they have a polycystic ovary, and 10% they will be slim. But even the slim people, they will have a complication of PCO. This is the problem with the PCO. So it's really impact on the reproductive system. Meaning, if the patient is obese, she might be diabetic, she might be hypertensive. If she got pregnant, she will have a lot of complications. So for us, even as a pregnancy, we wish that she reduce her weight. So what's gonna happen to them exactly like this? So they are obese, overweight, abnormal cholesterol, and the cycle goes on. Insulin resistance. So we always goes with the insulin resistance. The problem with the PCO, they gain weight, more fat, more type of E3 that's produced by the body, and that cause insulin resistance. So they produce the insulin, but the tissue will not absorb it, will not burn the fat. That's the issue with the PCO. Like, what's the cycle and what happened exactly? So, as we mentioned before, PCO affect about 25% of our population here, and it's associated with type 2 more, in which as well, obesity is more than other diseases. Like, if they have a diabetes, they might not be obese. But with polycystic ovary, most of them they will have. So I wish if we reach with the bariatric surgery doctors, if you see an obese patient, just screen here for polycystic ovary. Because I think as a bariatric surgeon, it's really important for you, the success rate. And make a huge difference because you're doing a lot of effort. And you do the sleeve, you do the bypass, and guess what? They gain weight. For you, it's a disappointing thing because you did your job, but the patient does not figure that way out. And then after the bariatric surgery, oh yes, you have a polycystic ovary. That's why you gain weight. So if I wish if we deal with the screening test and all this stuff and to make sure, especially with the female, before they went to go to these type of surgery, they will be managed and diagnosed before going to this surgery. Because it's really effective, and we've seen them. But things that they don't know that they're easily to gain weight. Even with a small amount of meal, they will gain weight, and you will see now. Like, as we may know, excess body fat, insulin resistance, and hyperinsulinemia what happen, and the decrease of the sex hormone binding globulin. So more of the free testosterone will be in the body. So the LH will increase too, and that will cause anovulation. Right. Even when they don't have an obesity, that the 10% we spoke about, insulin resistant is present in almost 80% of them. So that's the issue with the PCO. Even when they're slim, they have some sort of insulin resistance, but they are fighting it. They're going to the gym, they're doing diet as much as they could, especially they're young. But as you may know, when you reach each decade of your life, the metabolism will change in your body. So at a certain point, she will get pregnant, and guess what? She cannot go back to her weight, and then you discover that she has a PCO. But another risk factors as well, the chronic vascular diseases in the PCO is much higher. And as well, and the woman with hyperandrogenism. Like PCO, what does it cause to the patient when they have an obesity? Anovulation, meaning irregular cycle. Type insulin resistant, type 2 diabetes, metabolic disorders, cardiovascular factor, sleep apnea, okay, endometrial cancer, pregnancy complication. Why we hate the obesity with the PCOS? Because when they do the fasting, the GnRH pulse will decrease. So we're good. She doesn't gain weight. But with the high calories, that's what's going to happen. The leptin will get higher, and that's part of the physiology. And with the leptin going higher, the other mechanism will keep going, and the gonadotropin level will go high, and the LH will go high. So what happens if the LH goes high? The insulin resistance will increase. It get worse. So no matter what you do for them, it's not getting help. So that's why these technique, bariatric surgeries, came us to help to decrease the intake if they don't be able to do it by themselves. And unfortunately, most of the patients, they cannot control that because they don't have the vision what to do or not to do. With the leptin and the leptin receptors mutation, what happened is they will have the phenotype of being obesity, and that obese, sorry, at which is the hypogonadotropic hypogonadism status for them. So what does it as well affect the obesity when they reach the obesity with the PCO? It affects the sexual dysfunction. They will have a decreased libido, they will have decreased arousal, as well as reaching orgasm or early orgasm. And this study shows what are the figures here, as we can see, at the scores with them too. This is a meta-analysis was done as well, showing that obesity with the PCO, how does it affect the sexual drive? It's really decreased, and most of them, they lose the interest, and they don't like it. So this one is a meta-analysis. So as well as with obesity by its own, it causes the spontaneous abortion, which is a recurrent, which is a challenge, and you will see with Dr. Sabban. Most of the ladies, they come to us with the PCO. The main concern and the first thing they will ask in the clinic once you reach the diagnosis, am I be able to get pregnant? That's the first question. The answer, yes. But yes, what? F. What are the Fs? We will see. If you decrease weight, if you have a regular period, if you have a regular ovulation, then you're going to get pregnant. So how could she reach that if she's obese and the BMI is more than 40? The chance is very minimal. So as well as you can see the figure, once the BMI increased, the risk of abortion increased too. So it's reached up to 15% to 38% if the BMI is more than 30, which is too much. As well as the impact of obesity with the pregnancy, it's more than, if the BMI more than 30, she has 3 times more likely to develop GDM, which is the gestational diabetes, as well as if the BMI more than 35, the chance she will have 2-fold of the normal population to have a preeclampsia. So by any means, PCO, it hits really bad. And the main risk factor with the PCO is the obesity, and we see it really common with this patient. So how could we help this patient? Now we spoke how bad is the PCO with the obesity and how is obesity is really bad for the impact of the life of the female. How could we help them? Is it enough to reduce weight alone? Is it enough to get a medication? Is it enough to have a surgery, a bariatric surgery? We'll see now. So losing weight, the benefits from it, it's really unbreakable, like really changing her life. So we start the first thing, lifestyle change, diet, exercise. Most of the ladies, when they come to the clinic, they will tell you, I need you to do diet. This is the first thing I tell them. The answer, well, I will get, Wallahi, doctor, I don't eat. صح؟ يعني even in your clinic. Yeah. Yes, exactly. So if you are taking one meal, your metabolism is really low, and your metabolism is already super low. Right? So what's the point of doing one meal? No, you need to be like a diabetic patient. You have to take 3 meals and 3 snacks. You have to avoid carbohydrates, all this stuff. Like they're trying their best, but honestly, I've seen them. They stick to the diet. But with the insulin resistance, if someone as a female goes with no PCO, she goes to the gym for 1 month, she might lose 3-4 kilos. And this PCO patient, she might lose only half kilo. So that's the frustration with the PCO. No matter what they try, it doesn't help as much as doing all the stuff together. So what other stuff we can combine with? Pharmacological agents, we can start with metformin. Nowadays, we have all the type of injections that help with the reducing, affecting the CNS center for appetite and this stuff. But does it work alone? No. The problem is it's a temporary effect. Even the metformin, it's a temporary effect. And you will see with the metformin, how big is the study show that the PCO with the female and you start metformin, what is the impact is really minimal if it's alone. But she has to be on a diet, with a well-controlled diet, trust me, like if she skipped 1 month, she will gain all the weight that she lost in the previous 6 months. And we've seen a couple of cases, me and Dr. Ali, when we were together, they had this. They had the sleeve, PCOS, they lost weight, and then they gain it in 3 months, like 15 kilos, which is really frustrating. And honestly, we were like scratching our head. So what shall we do? Even we reach a point that to offer them to have a variant relic, because it's a type of treatment for PCO to decrease the insulin resistance. And some studies goes with it, some studies say no, because even with infertility, it doesn't help the fertility. Right, the third thing, we go with bariatric surgery. So if we combine these three, we might help these patients to get over it. Why? Because lifestyle alone is not enough. Okay, medication with the lifestyle, it's not enough too. Okay, bariatric, yes. Why? Because it prolongs the period for them. Because she's in the childbirth like age, so she would like to get pregnant, right? She will have children. Appetite will increase, and mashallah, our people, they love food. So you can imagine, it's hard for them to control with the diet. So you need a push, you need a medication. Okay, you need a bariatric surgery, yes. But treat it as its own, it's one of the obstacles even up to now for obstetric and gynecology. Like the first thing I will tell the patient, please try to reduce your weight. And the answer I get, I tried so many times, but I can't. What shall I do? I tried even this injection and didn't work. I had the sleeve, didn't work. So really keep it in your mind, please. PCO is really, it's not the failure of the surgery. It's the PCO problem. PCO does not help the patient to reduce weight. Sometimes you see miracle, but most of the time, unfortunately, because the obesity is more than 80%, it's kind of hard because it's related to hormones rather than habits. Okay, so these are the intervention. You can have a low calories. And this is another problem. When you have a low calories, most of our patient does not stick to it. Like imagine your life, you're eating 800 calories. No way. So they cannot survive on this. So the target is to decrease the meal, to make multiple meals during the day, as well as the exercise. Don't skip any day with the exercise. So the target is that you have a SMART, which is a specific, measurable, achievable, realistic, timely diet, as well as with the exercise too. That will help to decrease the weight as much as possible, with as well giving them a medication. So metformin here. Most of the studies, as you see here, that is really helpful to reduce the weight. But the problem with metformin has a temporary effect. You cannot give it to them for a long time because of the side effect. This is number one. And lifestyle was superior to metformin. Guess what? So metformin alone does not work. You have to change your lifestyle. If you don't change and you rely on the medication, that's what that. So I'm not here as a pediatric surgeon, but I will say, if the patient reaches a point that she's using a medication from the studies and doesn't help, and she's not following the lifestyle, pediatric surgery is the solution for her. But she has to know, if she fooled around with the diet, she's going to go back, even after having a sleep or having a bypass. Because this is really important. They think if they get the injection, they will lose weight and it's forever, it's gone. No, once you stop it, it will go back and it will go worse. So as you can see here, metformin alone is not really helpful. If you see lifestyle intervention was superior than metformin, and you will see as well in the next slide too. So metformin does not increase the chance of having a live birth, okay? And metformin is not the first line of treatment with the management of PCO. So the lifestyle, it is the first line. Metformin just to help, just to push the patient to keep going and to lose weight. Like, this one you will speak about, but I just mentioned it here because we usually recommend if the patient would like to go underneath the or having bariatric surgery, she's supposed not to get pregnant for at least 1.5 to 2 years. Like, what is the impact? Even you can educate your patient. What is the impact if she got pregnant and recently after the surgery? The impact is on the baby mainly because it will be malnourished. The baby will be IUGR, small for gestational age, and these complications. But other than this, if we follow the growth and the growth is fine. So it's okay. But we prefer to be at least 1.5 years to 2 years. So, in conclusion, does the obesity affect fertility? Yes. Does it reduce the success rate? Yes. And there is no single intervention is really effective. You have to combine all. But if the patient really failed the medical treatment, the only solution is to have a bariatric surgery. But I think the question is which one you will choose, the sleeve or the bypass? That's really a good question. I wish to hear from you as a bariatric surgeon, which one is the best from your experience with this type of patient. And there is no evidence that the weight reduction is difficult in the PCO other than other women. But it's just a matter of how you approach it and how you take the patient. And the combined intervention is really needed because one solution is not enough. You have to reach all the channels to reach the goal that you want. Thank you.
Thank you very much for this, all this information. As for our meeting, I said pediatric gynecology it became part of our life because the majority of our patients is female and they have such problems, and we should learn more about and to learn from you and your colleagues are all of you, the gynecologists, because there is many things you cannot, we should, every specialty, we should know our limit. So we would like to open the discussion and allow me to be the first since I am here, sitting here. What is the prognosis of the treatment? Because we miss the patient, we give the lab for each patient. All my colleagues, they will agree with me. That is, you have PCO, and I want to to reduce your weight, and this without to speak about such good, nice scientific details. But what is the prognosis of the the prognosis of this disease for the patient? It will like for us the diabetes or the hypertension, it's almost diminished. But for the PCO, what we have some data regarding this point?
Yes. The problem is most of the data, they are not concerning Saudi Arabia. As you know, our culture is different than the other culture. When they diagnosed with the PCO in North America and they told them you have to stick with the diet, they don't have to stick with the diet because they have the awareness of the later problem, which is like diabetes, high blood pressure, complication in the pregnancy, and obesity by itself, cardiac diseases, stroke, all these stuff. So we cannot apply these data. Unfortunately, here in Saudi Arabia, we don't have much data about the PCO with obesity and bariatric surgery. But what I would say and summarize it to all my patients usually, you have to have the awareness. What is your point? What do you want to do? You want to lose weight? Well, all what you care about is just to get pregnant. If she only wants to get pregnant, she will lose weight for a period of time and she will gain it. So awareness is the most important thing. And she has to know it's not only a magic, like, touch and the patient will lose weight. She has to work hard for it, harder than the others, as well as she has to take the medication. She has to consider the surgery. The most important, I think, goal or a message for these patients who are underweight, all the surgeries to tell them, you have to stick with the diet, even if you had your surgery. Surgery is to help you to lose weight, but you might easily go back with the weight. So the figure that they will improve after all these combined approaches, about 20 to 30%.
Thank you. Anyone?
So do you have special recommendations which patient should be screened before bariatric surgery? If the patient comes to me to the clinic and she's overweight, she's having some menstrual irregularity, but she's not yet married, so she's not continuing with fertility. So we should screen those patients or we should embark go ahead and do bariatric surgery?
Actually,
if they're BMR?
if you're at your institute, what you could do is just like what the our colleague in dermatology do when they come with the acne. The first thing they will tell them, please go to the gynecologist and make sure that you don't have a PCO. See, even with the acne treatment, they suffer because the insulin resistance and the high testosterone, so they will have more acne than the others. So what I would do, if you have the knowledge, and that's why we're talking about it here. If you have the knowledge, ask about the regularity of the menses. If it is abnormal, ask if there is a family history of PCO. These two questions, it will be simple and give you a clue where you're headed.
As you mentioned earlier, they have insulin resistant cancer, is it?
Exactly. Yes.
Yeah.
But now with the laser, that's the fact that you don't find that.
No, and the second thing, is it really difficult to diagnose PCO?
No, it's not actually.
Yeah, that's why my colleague was asking, because we face a lot of females that actually do tend to have all the symptoms. And we can pick it up, but they come and we send them to gynecologists, they can't.
Rotterdam. Yeah, usually we go with the Rotterdam criteria.
Right.
Basically, it's the three things. If you get 2 out of 3, this is your diagnosis.
Right.
The first one is having a regular period. The second one have a ultrasound that's showing it's a polycystic ovary, but there is small note that some of my colleagues fell on it. Don't do the ultrasound, especially when she's young, when she's ovulating, because it's gonna show as a PCO. Do it either she has her period or maximum 1 week after the period. And the third thing is the clinical feature of hirsutism. Before we used to use FSH, sorry, but it's not part of the criteria. The only thing you can do is the testosterone, and you will see it high upper normal. So it's normal, but it's high upper normal.
Okay, I just wanted to ask you, just about you mentioned something about the fetus, and it's the effect of bariatric surgery in the fetus in the first year, if she ever gets pregnant within the first year of the surgery. And we had many data over the past few years, starting I think about 2016, as far as I went back, and it shows really that there is no effect with sleep gastrectomy. There is no effect on the fetus, but most of the effect really is concerning the mother herself.
Yes.
And second thing is you asked about the type of surgery, and there is a recent published data that showed that sleep gastrectomy doesn't really affect the fetus, but the bypass patients, they get pregnant within the first year. Bypass patients, they tend to have yes, underweight kids, and probably that answers your last question regarding which type.
Actually, the weight of the baby will decrease because of the malabsorption that happened to the mother. So the baby will get affected.
With bypass, right?
Exactly. Yes.
Any other question, please?
Yes, what is the best option? Contraception, you use it, what is the best contraceptive method you use for post-bariatric patients?
Honestly, I would try to avoid anything oral because we know there is some malabsorption, so the chance of getting pregnant will be higher. So either the implants, or they can use the patches, or you can use the IV.
Actually, I have convinced that most of the studies about the fetal outcome of the bariatric surgery is not from our culture. I hope that we see here from our country studies regarding the pregnant ladies post-bariatric patient, post-bariatric surgery, regarding the prenatal conditions, antenatal and postnatal and the fetal outcome. I think this would be a good study to find out what is the best for our culture.
Exactly. The things that as well, they mentioned for 1 year and a half, so the patient will go back to the diet normally, because in the beginning they will start with the fluid and this stuff. Here we're the dangerous zone for the patient and for the baby. First, the baby will be indirectly that affected because of the reducing weight. That's why we said it's only the weight will be smaller, but nothing else. Like it doesn't affect like the congenital problem in the baby, let's say. But just the weight, because the mother weight will be like she's afraid to gain weight, so she doesn't eat. And if you remember, like with the pregnancy, the first 3 months they don't eat well, so that make it worse. So the patient will be malnourished as well as the baby.
And actually here in our culture, most of the patients that married ladies, they are really in a hurry to get pregnant.
Yes.
And one of the reasons because there is a cultural pressure around it.
True.
So once she do the operation, she does not want to wait for another year. So they get earlier compared to other countries.
Very true.
So most likely we will see differences.
Oh, yes, a lot.
Routinely, we put them on supplement after we do surgery, like during sleep or when one gastric bypass. So we put them on supplement like temporary or lifelong. So if she get pregnant, there is any modification in the dose of the supplement?
Exactly. Yes, like let's say if they have a vitamin D deficiency, we'll not give them the 50,000. We'll give them the doses that maintain the level that she got pregnant on. Because if the sequelae, if you give them the 50,000, it causes a problem with the baby. If you give them vitamin D injection, it will cause a problem with the baby. So we give them what maintain the level in their body once they get pregnant. And what I would advise all the patient who underwent the bariatric surgery to have all these investigations done. Because nowadays, the main talk in obstetric is relation between vitamin D and recurrent miscarriages. So if we correct vitamin D before she gets pregnant, if we correct vitamin B12, that will solve a lot of problems. And I think that's the point I was talking about, which is the PCO and obesity and this stuff like causing recurrent, as well as when they have their surgery, they will be afraid to eat anything, or they will be afraid from the vitamin to gain weight. So some of them, 3 months, 6 months, you see them in the clinic and then they will disappear from it. And here where the issue comes. So that's what I said in the beginning, awareness, we miss it here. So we need really a lot of awareness for all patients.
So the advice, once my patient getting pregnant, I will advise her to stick to her obstetrician doctor and follow his advice.
Yes, exactly, because we give them multivitamin, we do give them iron, we do give them as well calcium.
Yes, thank you very much. The next, we will invite our colleague, Dr. Batayyah, to tell us about the relation between the surgery, the bariatric surgery for patients with PCO, which is the point now after this nice presentation from our colleague, the main economist.
Sharing the screen. Sharing. Bismillahirrahmanirrahim. Thank you. It's difficult to come after Dr. Fahad Gracie and his expertise in the field, but now I'm going to talk about polycystic ovary from bariatric point of view. So I understand from what has been started and we discussed, we have 3 or 4 questions we need to answer. First question, based on what I read and on my review, there is no clear guidelines regarding PCO in ACMBS HSU guidelines. So the current guidelines talking about BMI 30 and above with comorbidity, 30 and Asian 27, with comorbidity, diabetes, hypertension, dyslipidemia, etc. So PCO, can we consider it as diabetes? So there are no clear guidelines. Primary fertility is another issue. Shall we consider it as guideline? BMI 30 and above. So this is not clear. So this is the first question we need to answer. So is PCO is an indication of diabetes it's a metabolic disease, metabolic syndrome. Obviously, from what Dr. Fahd presented, it's a metabolic disease associated with insulin resistance, even if the patient did not show signs of diabetes like high blood sugar, hemoglobinurias, etc. So this is the first question. What's the cutoff for doing bariatric surgery for ladies with PCO, especially in primary infertility? Second question is, what's the type of the best procedure? There is heterogeneous data in the literature. Most of the studies, as I'm going to show you soon, talking about monogastric bypass. We know the challenge in polycystic ovary is that there is insulin resistance and they have difficulty to lose weight like those having PCO. So is the bariatric sleeve gastrectomy is enough that they're going to benefit? Or shall we upgrade to gastric bypass or even to peripancreatic diversion, whether study or renal switch? Third question, when should we offer what type of based on patient age, childbearing age? So when we should ask the patient, give the patient green light to conceive after bariatric surgery. So this is another issue. Patient came to me, primary fertility, she did surgery. Suppose she's looking after 10 months to be pregnant. And we have, most of us have examples of this. So what is the cutoff regarding the time of pregnancy? Is it 1 year, 1.5 years, or 2 years? That's the main question that we need to answer and talk about. So I'm not going to repeat what my colleague has spoken about. So as mentioned, is high prevalent, is associated with obesity and associated with infertility. The problem is that there is no clear evidence what the best mode of therapy should consider on those patients, especially if accompanied by infertility. Most of our colleagues in gynecology, they will start to lifestyle modification with medication like metformin. I'm not sure it's with anti-obesity medication, generations new, etc. And when we should consider bariatric surgery. Regarding the diagnosis, as mentioned by Dr. Fahd, so it's difficult to diagnose for us and for some of general gynecology. To be honest, really it's difficult. We got a lot of patients. They are following with the gyne or obstetrician, mainly they are not that, and they don't have the clear diagnosis. But according to the criteria, we have like 1 or 3. Okay. Either hyperandrogenism or ovulatory dysfunction or polycystic confirmed by ultrasound. Now, when we talk about the polycystic ovary syndrome, what are the effects of bariatric surgery? Most of the evidence, there is no doubt that the bariatric surgery is the best. The best procedure, approach, best therapy for treatment of polycystic ovary. And this evidence, this is one of the earliest studies done. It showed the improvement in the insulin resistance, improvement in the free lipid testosterone level, improvement of the health specimen, their decrease in the health specimen, and their ability to conceive. It's increased afterward. Again, this is another, also talking about coronary bypass, and it shows out of 23 completely resolved. 12 of them, almost half of them, they have completely resolved hirsutism. They have their fertility and the menstrual cycle normalized. Now we have another study about sleeve gastrectomy. Sorry, this is a normal gastrectomy. As I told you, most of the study, I will give you the review of the most of the study. Okay. This is another one about sleeve gastrectomy. This is done by Wang and showed that there is improvement in body mass index, in insulin resistance, and also in hormonal parameters related to polycystic ovary. So, in the conclusion, it is that there is pronounced improvement in resolution of menstrual cycle and ovulation noted in patient post-sleeve gastrectomy 2, and observed in the first 6 months maximum and up to 1 year. Another study talking about sleeve gastrectomy development to the inflammatory marker. they found that C-reactive protein has been improved after bariatric surgery, and maybe it has relation with polycystic ovary disease. So these are, I'll show you just all these studies. You can see the type of the procedure has been done. Most of the studies are retrospective. Unfortunately, we don't have randomized controlled prospective studies about the role of bariatric surgery in polycystic and which is the best operation. So most of the studies, retrospective analysis, both sleeve and bypass has been tested, and the best from outcome from all the literature I have reviewed, gastric bypass. Gastric bypass have superior effect. Sorry, the first is the peripancreatic. There is the first one was peripancreatic diversion and gastric bypass. I want to assume, the first study, there was the studying effect of peripancreatic diversion, scopinaro, and gastric bypass, and it showed higher effect. Okay. Then sleeve gastrectomy, of course, banding is not anymore option, although it's been tested in the literature and showed some evidence. This is how bariatric surgery works. Actually, it helps to decrease the hypergonadism. Also, it decreases the inflammatory markers, also improve the insulin resistance. So obviously, the bariatric surgery is not only on base of weight loss, it's based on hormonal and metabolic effect, both whether bypass or sleeve gastrectomy showed a greater response. So, as I mentioned, there was a position statement by SMBS about the fertility and fertility 2017. They showed that there is an obvious benefit from bariatric surgery on the fertility, but they did not engage on the indication per se. The second thing, they did not talk about it is unclear whether what are the bariatric surgery would cause in delivery or during antenatal period. What's the complication of bariatric surgery was not clear in this study. The current guideline, this is the latest updated, which is BMI 35 and above without comorbidity, 30 with comorbid like diabetes, and in Asian around 27.5. So this is that it gives in opinion, what is regarding the time of conception. Sorry, I did not print the study. There is I think the Swedish nationwide study. They studied more than 24,000, I think, ladies who were pregnant after bariatric surgery compared to non-bariatric surgery. They found the increase of abortion, stillbirth, and the most common is the low for age or low weight for age. This is the most common fact. And they recommend, by the way, 18 months. But most of this study in the Swedish, which is nationwide, was about gastric bypass. There was not much case of sleeve gastrectomy. Now, there is a recent American College of Gynecology and Obstetrics and Gynecology. They published that they should wait from 12 to 24 months post-bariatric surgery, but they did not clear up what type of bariatric surgery. So it is in the gray zone. I would say sleeve, I would wait for 1 year before asking the patient to conceive. Gastric bypass, 1.5 years. Should be at least 18 months. And probably 24 months is the best. So the question that is still hanging, sorry, for our experts and for our audience, and been posted into the WhatsApp group, what do you think the best bariatric surgery can be offered to a young, otherwise healthy woman coming to you with PCO and infertility? Do you offering bypass, sleeve gastrectomy, SADI, MGB, whatever? And the second question is, what is the cutoff BMI you can offer bariatric surgery for patient with PCO? So this will leave it for discussion. I don't think it is this clear answer, but maybe we have to get view from our expert.
It's true or false, yeah.
No?
Scientific.
حطينا فوت في الجروب في الجروب حاجة scientific.
Thank you, Dr. Ali, for this comprehensive, even though we are getting more confused. Marvelous. And the money is all for this.
Yes. I would like to start asking, there is any hints regarding why the gastric bypass is superior to the others, or just because of the magnitude of the weight loss?
But as I mentioned, the superior because most of I have two analysis review, okay? And most of them, the most was the long-term follow-up, and the most of studies was only gastric bypass. For that, not exactly. So the sleep was not tested so much like gastric bypass to see the evidence. But from our knowledge, we know sleep gastrectomy weight regain is higher than gastric bypass. And those patients with PCO, they have higher tendency to regain their weight in a shorter time than PCO patients. I think this is the two factors that affect
One more thing regarding the secondary infertility. The secondary, as I have seen in the literature, when we prepare for this, the secondary infertility is the most common in the obese patients because they manage to have good consumption in the first. After that, they increase their weight and they, so I want to emphasize this.
We have seen patients doing people surgeon doing surgery, bariatric surgery for diabetes normal BMI. So why not for other?
As I told you, the guidelines, the ISMS guideline for IPSO guideline did not mention clearly about is it do we consider PCO metabolic syndrome or not? Because it's being mentioned clearly, diabetes, hypertension, dyslipidemia, etc. So the guidelines, the guidelines, infertility or PCO was not clearly mentioned, but is recommended even by American College of Gynecology. They mentioned their guidelines that it's a bariatric surgery is considered in case of failed medical and other care. But the cutoff BMI, I'm not sure, shall.
I mean, the result of PCOD, or the PCOD is a result of obesity.
والله this is all leave it for the experts. طبعا regarding your question, Dr. Hammo, fertility and secondary fertility. Now Dr. Hussein will talk about infertility and he can answer most of our question. But which comes first? Obesity or PCO? Obesity?
No, actually, it's the PCO that causes that. Yes, the insulin resistance.
And Dr. Mahmoud, السؤال حقه كان it's really like relevant one. PCO does cause. Well, this is the problem because if it is obesity alone, you can't find many ways to decrease the weight. The problem with the high insulin resistance, they can't lose weight easily. Like the thing that I assume why they didn't put it in the guideline whether PCOS is metabolic syndrome or not, because of there are two types of the PCO disease and the PCO syndrome. Okay, so that's making a huge difference. So they cannot generalize it and make it as a metabolic, because if they have a metabolic problem, like diabetes or high cholesterol and this stuff, then we call it a syndrome. If it is only disease and regulated period, there is no obesity, we call it a disease. That's the reason why.
سيليا واتس يعني عندك سيليا واتس حقنا ساعة بس Yes. For those, our colleagues who sharing with us with the Zoom or the live streaming, if they have any question, they can post it on the WhatsApp group of scientific, or they can, we can have one or two questions if our chairs agree to have them, because the voice is clear, we can hear them, they can't hear us. Was it the lead?
Assalamu alaikum. Thank you for the invitation and the presence of one. So I will just comment on the topic which is best for the PCO patient. I would like to ask you, the expert, would you prefer to do, if you have a patient with a high BMI, would you prefer to do a surgery right away, or you start the medical management? Since we have now on board the medication that are actually treating the obesity, like the injection. That's a very hot topic now.
Yes.
So what do you think?
Yes, this is, yes, in the state, to learn from you, want to learn from us. Really, it's a dilemma, yes, but when we go through, and I think my colleagues, as we mentioned in the beginning, that is the majority of our patients is females. And they are, honest to say, they are brave patients. They want the solution as quick as possible for many symptoms they are suffering from. So it's, for me, it's the combination of these two problems is a syndrome. So for the solution in our hand is our weapon is the bariatric surgeons. So when we do it, I think all my colleagues, they went to through this experience, they have dramatic good results. But the deep wise, we should discuss.
We should dig deep. There are more and more studies now coming with studying the PCOS patient. They did study using the only study was done for the medication was done for PCOS patient was using Saxenda actually, and they found there is good improvement in ovulation, okay, and also pregnancy for the patient who are using Saxenda. I don't have the data on me. I just but maybe it's another topic that we should see if the medication actually is a good choice for PCOS patient. The reason why I'm saying this because with a lot of patients, they're actually with advanced maternal age and they've been suffering from infertility for many years now. And once we tell them that you should go to actually a surgeon, an expert, because you need a surgery, okay, they will ask then, when can I get pregnant? And that's the real problem here. Okay, if they are advanced maternal age or obesity, they should wait for 2 years. They're thinking about a family. Once they reach the age of 37, they will have decline in their oocyte quality and number. And we're gonna face a problem with those patients because maybe they can conceive with the first baby, but maybe the second or third, we're gonna face a problem. So maybe in the future we'll find medication, maybe will work faster, and I don't know, but it's a big question we should answer really. So I'll start my presentation with the first thing or last question. Again, why we would have a limit and a BMI limit for patient with going for infertility treatment. So we found this once I started my fellowship, they said you have to have a BMI of 30, then you can go for infertility treatment. I'm just like, why? I said, okay, this is my mentor told me why. I said, maybe because of anesthesia risk. Actually, it's not only because of anesthesia risk. Good, because of anesthesia risk, yes, we're doing our procedures under deep sedation and conscious sedation, but we found a big problem with those patients, with the PCO patient and obese patient in the lab. In the lab, those patients usually they are suffering from number one, lower quality egg, lower quality sperm, and at the end, lower quality embryos, lower pregnancy rate. And then, like you will, as mentioned maybe by Dr. Fahd earlier, those patients, they have huge number of oocytes, huge number of eggs. They have higher ovarian reserve if you compare them to a female the same age. But the problem, those oocytes, if you collect them, they're actually lower quality. We can collect maybe to 30 at one cycle, 30 or 40 oocytes. But what we can use, usually maybe less than half, less than 50%, we can utilize those oocytes. So there's a big problem with those patients. And the second problem is the obstetrical complication associated with obesity. So obstetrical complication is a huge burden. So those are the limits. So they put the BMI of 30 as the limit. If for any patient we're going for infertility treatment, specifically talking about IVF, and then same thing, we try to apply this BMI of 30 here, and we face a big problem. It's like BMI of 30, you cannot do any infertility treatment and unless you lose your BMI less than 30. It's a big problem. So what is the impact of obesity on fertility treatment? As I mentioned earlier, sorry. Huh? Ah, okay. This one? Okay. Okay, so first of all, we'll have impact on hormones. As mentioned maybe by Dr. Fahd earlier, there is a big impact on hormones because of the obesity. The second one is the menstrual irregularities. Patient with PCO and obesity, they have sometimes they have amenorrhea just because of the obesity. The third one is ovulatory dysfunction. Usually patients, they have anovulatory cycles. Their cycle even longer than 45 days. They don't ovulate normally. Once they tell them you can use the ovulation kit, they go and use it. They said, I used this ovulation kit for almost like 30 days and I have zero positive stick. So because she's not ovulating because of the obesity and the PCO. On male, we find a decreased sperm quality, motility, and even number because of the obesity. The patient, they have, as I mentioned earlier, there is a big impact on the ART technologies because of the obesity. Oxidative stress now becoming a major impact. Many studies done on oxidative stress because of the obesity and the PCO as well. As you know, it's also associated with insulin resistance. Now, one of the major medications that we're using on all infertility patients, as male or female, we're using a lot of antioxidant medications such as CoQ10 or vitamin E. There is a higher risk of miscarriage, of course. So what is the exact impact on the because of the obesity on ART treatment? So the factor number one, for patients who are doing ovarian stimulation, when you use ovarian stimulation, we're using gonadotropins, injectable gonadotropins. What we found, and in many studies and systematic review and meta-analysis, they found actually patients who are obese patients, especially BMI more than 30, they found that those patients that are requiring more or higher doses of gonadotropins because of the absorption. Because of the poor response. So can you imagine patient, she has a 30 or 40 follicles, and you're giving her a maximum dose of the medication, and she's poorly responding to your treatment. You're giving her 300 units or 400 units of gonadotropins, and she's not responding because of the poor absorption, because of the obesity. Second factor, oocyte recovery. We're having difficulty. We're doing our procedure transvaginally, so it's very difficult to do transvaginal ultrasound and transvaginal ovum collection with a patient of a BMI more than 30. It's very difficult and it's dangerous. Sometimes we can't even reach to the ovary because of the obesity. That's a big problem. Second fact, that's the number and the quality. In many studies, also they found the number and the quality of lower quality and lower number with those patients, especially if the BMI more than 25. The fertilization is a big issue. We're having a big issue with the fertilization, especially with the PCOS patient and the obesity patient. Cycle cancellation, we're encountering many patients, we have to cancel their cycle because of their poor response. They don't respond well to the treatment because of the obesity as well. The only good thing about obesity and fertility treatment, actually, they have lower risk of ovarian hyperstimulation syndrome. So if you have a PCO patient, a thin PCO patient, she's at a great risk of ovarian hyperstimulation syndrome. But if you have an obese patient with PCO, she doesn't have a high risk of, that's the only good thing about obesity and ART treatment. Also, they found those patients, even if we were able to collect good eggs or we have some eggs and we're able to create good quality embryos, they have obese patients with PCOS, they have lower implantation rate, lower pregnancy rate, and a higher miscarriage rate. I found many like new studies done, and one systematic review and meta-analysis, not meta-analysis, was published in 2022 in Human Reproduction. They were talking about the effect of bariatric surgery. There is a good impact by bariatric surgery on fertility treatment. They found better oocyte quality, better embryo quality, and higher pregnancy rate, lower miscarriage rate. Also, there is another study done this is published in Sterility. Also, this is a journal by the American Society of Reproductive Medicine. They did a study. They looked at this center and they looked at around 48 patients who had done a bariatric surgery, and then after that, those patients went to do a fertility treatment. What they found is those patients have a better quality embryo and a higher pregnancy rate, and also they were able to actually do freezing for those embryos, which will what we call it cumulative pregnancy rate. So if this patient did not get pregnant from the first cycle, she will be able to use the same embryos that she collected from this cycle. So she will have at the end what we call higher cumulative pregnancy rate. So they found that patient who had bariatric surgery, they have a higher cumulative pregnancy rate. So I think, answering your question, Dr. Ali, I think soon enough from the reproductive societies, you will find that they're actually recommending bariatric surgery for
those patients are suffering from infertility because many data are showing we have a better outcome for the sperm quality, the egg quality, and the embryo quality, and a higher clinical pregnancy rate and a higher live birth rate. This is what the patient wants, a live birth. They don't think about our side, they want a baby. So many studies are showing now higher pregnancy rate and higher live birth rate for looking after pediatric surgery. I think it's still soon for us to see the effect of the injectable medication, maybe after many years from now, but for now, I think soon enough from European Society for Reproductive Medicine, American Society, Canadian Society, they're all publishing that the pediatric surgery should be considered for those patients suffering from infertility and going for a ART treatment such IVF or ICSI. Thank you.
You're very much Dr. You encourage us to continue helping the females for the problem of the fertility, either the primary or secondary. But I want to bring you back all to the history. When we started laparoscopic surgery, the gynecologist was aware of laparoscopy, but not very much over it. They was very much fun and very happy with one of the procedures with monopolar as a surgical treatment, and they asked us as surgeons. At that time, it was a lot of operations. Now there is no any surgical option or the obesity will take this.
I think for the surgical option, use it for the monopolar, using the cautery to
Yes.
decrease the thicker cell mass, especially for PCOS patient. Now it's almost contraindicated in our field.
You don't know how.
It's not recommended anymore, actually, by all societies now. It was one of the first in the guidelines. It was on the first, maybe the first guideline, but nowadays we don't do it anymore. We don't do that surgery anymore. It's not recommended because what they found, actually, two problems. Problem number one, it's associated with adhesion, infection, and complication. The other important factor, actually, it's associated with a lower ovarian reserve. Low ovarian reserve. So those patients will, in the future, will suffer from low ovarian reserve.
I know some of my colleagues, they said that is, yes, hamu is the old fashioned, but it was the butter and bread of all the gynecologists.
Yes.
Yes, because Dr. Adil is laughing as he called our generation dinosaur. Thank you. So any other question, Adil?
Shukran, Dr. Hussein, for this talk. It was very informative. And I have just a comment and a question. The comment is regarding your question, the initial question, the role of the medications in obese patients. I think if the patient BMI reach to the level as indicated by the guidelines of IFSOS or ASCBS, then the surgery is the best because of the sustainability. But doesn't mean there is no role for this medication? Yes, there is. If the patient did not reach the BMIs enough to be a candidate for surgery, this is number one. Number two, for the patients who I can use it as a bridge, super morbid obese with a high risks, okay, then I can use this medication to reduce his weight and BMI and improve the physiology of his organs, then I will do the surgery with a low risk. Number three, for the patient who regaining weight after a bariatric surgery, instead of doing a revision surgery or redo surgery, then it is better to use the medication before we go for the surgery. My question to you is, what is the cutoff BMI for your patient before you do them an IVF?
هو الكت ideally 30
In Saudi Arabia?
Saudi Arabia. But we do, يعني we do, can we, do we do more than 30? Yes, we do. But in King Faisal, the cutoff that we use in King Faisal, it's 30. We prefer not to do more than 30. And,
So,
but actually in the real life, I'm saying my experience and my colleagues, either in the governmental sector or private sectors, there are patients are BMI more than 30. We're conducting IVF cycles on them. But as I mentioned earlier, those patients who are patients refusing any kind of treatment, they don't even take injections, they don't do surgery, they don't want surgery, they just want to get pregnant. This is the only thing they talk about. After counseling them many times, we still do some patients, yes, more than 30. I don't, more than 35, I don't, but 30, yes, we do. Between 30 and 35, we still do in the private sectors.
those patients with a BMI reaching 40, what your recommendation for them?
Go-
Medications or surgery?
Go to bariatric surgery.
Actually, I have one patient, she's in her late thirties.
Mm.
Her BMI is also around 39, and she was just following with a gynecologist for IVF.
Mm.
She came to the clinic, to my clinic, and she was asking for bariatric surgery. I told her, if you're gonna do the bariatric surgery, you have to wait at least like 1 year or 18 months for after the surgery to get pregnant.
Mm.
And now she got into that dilemma. I'm already 30, I'm 39. So what would be the best advice? To go ahead and try the IVF, or to embark on bariatric surgery and then wait for her weight reduction and then do the IVF?
Now, what my advice to do intensive weight loss program using the medication for 3 to 6 months maximum, and then we proceed with the IVF. The other thing that we can do nowadays that we actually, because of the dilemma of the ovarian reserve and the advanced maternal age, what we do nowadays, we do freeze all for those patients. So basically, if the patient really wants to get pregnant and she doesn't have a lot of ovarian reserve, so what I do the procedure, I collect those eggs and we create embryos, we keep them in the lab, 1, 2, 3 years, 4 years, she can come back, even after 15 years, she can use them. So this would be my advice. If she wants to lose weight, she can do intensive weight program, or she can do a freeze all. Then after that, she do the surgery. She will be, I can assure you, she will be happy. If she has at least 2 or 3 embryos, she will be happy. She will proceed with the surgery.
I'm just wondering, what happens with those patients that, they lose weight, they get pregnant, and then IVF or whatever, and then suddenly even if they get weight, they continue to get pregnant all the time. What was the whole cycle missed, or what was wrong before? Like they get for 8 years, they're trying to conceive. This happened twice with two patients I know. Like for 8 years, they're not conceiving, then they lost weight, they lost about 5-10% of their weight. They had an IVF, and then she got pregnant, and then she continued to be pregnant every other year. How can we explain that?
So you mean they lost weight?
Yeah, initially, but then, with pregnancies, they continue to gain weight.
So 25% of our population actually in unexplained infertility. Recently, New England Journal of Medicine, they published a large study for those patients with unexplained infertility. They found most of those patients, once they get pregnant once with IVF, after that, they have a higher spontaneous pregnancy rate. No one knows exactly why, but I can tell you those patients losing 10% of their body weight originally, that can resume normal ovulation. And definitely there is an 9% decrease if there is an increase in 1 BMI unit equal to 9% decrease in the pregnancy rate in the IVF. So that's a big number. So for those patients, once they get pregnant, I think there is something, what we call it oxidative stress. Now more and more we find about the endometrial factor, stress factors, all associated with inflammatory cytokines. Those patients, they have usually endometrial factor related to the inflammatory cytokines. And once they get pregnant, once this cycle has been broken, and now they can get pregnant without any intervention. Thank you.
Like, I shall sake of time, bro. Like now, if there is any question from the Zoom, so then we'll finish this topic and we'll move to last topic and different topic from what we started. The result of voting regarding what patient would be low BMI, we make it like wide range from 7 to 35 to 34, but mostly they said first intensive medical therapy. So 12 out of 19, they will go for medical therapy, I mean intensive medical treatment. If failed, will go for bariatric surgery. For the second question, what's the best bariatric operation for female with infertility? Sleep gastrectomy is almost exceeding, taking all the votes.
Everybody is voting for sleep.
Okay. So there's no question in the.
No.
طيب. You will conclude. أعطونا الخلاصة.
Yes, we have Dr. Osama, senior consultant.
لا خلاص التوبيك هذا عشان بعطيك الموضوع.
Yes, any more modern concept or from your references? Any question?
I think we almost already discovered, it's still dilemma about obesity and fertility. So I think that should be worth hard. All the studies from outside were based on gastric bypass, because gastric bypass was very common at that time. Now sleeping is becoming more and more of the world. So I think we need more studies.
Yes, we would like to invite our colleague Dr. Sam Keita, senior consultant, pediatric surgeon and thoracic surgeon as well. But I am sure just to introduce this nice cycle, that is, I am sure each one of pediatric surgeon now, their patient, even if they have done operation 10 years ago, doctor, I can pass or I cannot pass. So Dr. Osama, سوف يفتينا.
السلام عليكم ورحمة الله وبركاته. يعني نغير التوبيك شوية ونخرج عن جو البوليسيستيك اوفري. The reason for this topic today because this is the season of Ramadan إن شاء الله. فرصة احنا بنقول كل سنة وانتم طيبين. و from this point كنا نبدأ بالآية الكريمة شهر رمضان الذي أنزل فيه القرآن هدى للناس وبينات من الهدى والفرقان. فمن شهد منكم الشهر فليصم فهو أمر ومن كان مريضا أو على سفر فعدة من أيام أخرى. يبقى في شرطنا المرض أو السفر. يريد الله بكم اليسر ولا يريد بكم العسر ديننا دين اليسر ولتكملوا العدة ولتكبروا الله على ما هداكم ولعلكم تشكرون. يبقى الآية هذه بالحقيقة it put us in a very difficult answer to our patient. It's every year all of us we are confronted with this question. Do I go for fasting? I want to do fasting. In our society here, it's very rarely that you go in the street during Ramadan to see people drinking and eating in the street. Even the woman who has the option to break her fast because she's having her periodic menses, she do it in a hidden way, even inside the house. She don't eat in front of the children and the rest of the family. So this is very important, really important. And from here, we have to be careful. I'm sure every one of us, maybe he answered from his mind what is supposed to be the answer for his patient. I review majority of articles written about fasting in the month of Ramadan. It was written by Muslim guys, bariatric surgeons, and the conclusion comes that they advise that no fasting before 12 to 18 months, 1.5 years. If we give this message to our patient, I'm sure they will not respond. They will not listen to us. So we have to go for the other option. You will face the decision of the patient that he will fast. Probably he will go smoothly with no problem, but probably he will come with the problem of his fasting unless we guide him and to give him an advices. So the challenge here that special measures should be taken during Ramadan fasting for our patient to avoid health risk. So I have to slow them down. I have to explain to the patient, if really you want to do fasting, you have to consider certain issues. First of all, the eating behavior and the type of food we should eat in Ramadan. All we are doing fasting, 13 hours fast, and then you start to eat, you feel very hungry, and you start to eat the traditional food we used to eat it in Ramadan. Everybody, he said in Ramadan, I'm gonna lose weight. At the end of Ramadan, the people, they gain weight. So the quality of food, the type of food we eat, high calorie content, all this is a fact, is a risk factors that it could affect our patient. So in general, if I want to talk to my patient, that I give him the option to fast, he should consider that he should eat small, frequent meals, not to start by eating everything in the same minute. If he want to break his fast, he want to eat the date, he want to drink, and then he want to eat the sambusak and the soup and the main meal and the food and the tamis and everything in the same minute, that it cannot be. Because if he really try to eat this way, he will start to suffer from this decision. He should eat slowly, he should swallow slowly and masticate his food. He should avoid eating and drinking at the same time. This is an advice we have to give to our patient. And then he should really respect the feeling of satiety or the feeling of fullness. The problem we encounter with Ramadan, that fasting is due to the long fasting period, as I mentioned, and desire to consume large quantity of food at the time of breakfast. What could our patient develop? They should know that the price he will pay if he really start to eat in the wrong way, that he will start to have an abdominal pain. The abdominal pain may be due to gastritis, the stomach cannot tolerate, or maybe the abdominal pain due to the early symptom of dumping. So abdominal pain, nausea, vomiting, that it will lead to dehydration, malnutrition, that it lead to vitamins and mineral deficiencies, that he should really think about it. Do bariatric patients develop dumping syndrome during Ramadan? Yes, they do. And we should really consider it. If my patient try to call me by phone or to come to my clinic and he start to give certain symptoms, that I should think about it. Could be like an early dumping or could be the late dumping presentation. So when people start to eat, they consume big amount of traditional food full of sugar and dessert. What happened? After bariatric surgery, the mortality is very fast. So the emptying of the stomach to the intestine is quick. With the high concentrated items of food, that it will invite more fluid to go to the intestine, and the patients start to have the abdominal cramp and the abdominal pain and the diarrhea that it followed with the symptom of the early dumping. So diarrhea, abdominal cramps, nausea, vomiting, headache, tiredness, all this is representing the early dumping syndrome. And we should consider it when patient complain. All of this due to rapid gastric emptying, especially with food high in sugar, especially the table sugar, and even the fructose, which is the fruit sugar as well. It can invite for this symptom. Late dumping, it can happen. Yes, and patient, he could come to you after 3 hours from the meal and he start to have symptom of palpitation and sweating, which is the picture of hypoglycemia. We have to put this in mind as well. If I think that my patient is having dumping and I want to confirm it, so I have to diagnose it. So the history is important. We consider that not only gastric surgery, not esophageal surgery, even the mesenteric duplication patient, he could come with dumping symptom as well. This is in my review and it's been found in some of the study. So the history is important. Then if I'm thinking of dumping and I'm thinking of the late symptom, I have to request my patient to do blood sugar at the time of the attack. When he is feeling tachycardic and feeling sweating, is the picture of hypoglycemia, he need to do a blood test immediately. If it is hypoglycemia, this is support the diagnosis of late dumping. Then the radioactive material added to the food, and they can check and see the rapidness of the food going from the stomach to the intestine, and then the rapid absorption of the sugar that it lead the insulin to shoot up, and then the patient go into hypoglycemia. What I have to do with this? He's with you in the clinic or in the ER and he's having this symptom. So I have to reassure him. The early dumping, it can fix itself if he behave and he correct his way of eating. So again, the advice of small meal, avoiding the high calorie food and increase the amount of protein, that it would help him and his symptom, it will recover. We can also advise him that after he eat and he start to have the feeling that if he can lie down for half an hour, lying down, that I would say due to the gravity and helping the quick movement of the food from the stomach to the intestine, that it will be less, that it would help to reduce his symptom. Medication, sometimes sandostatin, it's been advised if symptom persists and the patient is still having an issue after he eat, and that it will slow down the gastric emptying. In long-term problem, if the patient keep having this problem, then probably surgery is the answer, that you have to reverse his bypass, for example, to put into normal physiology, that it would help to control. So at the end, my patient, he want to fast. Then I have to advise him to break his fast slowly. Start with water, dry fruit, maybe liquid meal like so. The main course should have high protein and vegetable rich. Advice, if you want to do fasting, to make his sahur late and to avoid the hypoglycemia the best he can. And again, advise him not to sleep immediately. Sorry for the spelling here. Myself, in Ramadan, I advise them to use the PPI as a prophylaxis. Yes. And then from there, if he can change his time of work from day to night, that would be better. So he can sleep after Fajr prayer the most of the time. So when he wake up only 3 hours, he can stand it till the breakfast time. Otherwise, if he really insists to fast, he should be careful that he avoid to work in a high risk, like driving cars, climbing heights, using a machine that he could injure himself. There is no worry if he start to feel drowsy, that he should break his fast. And at the end, we wish them Ramadan Mubarak, Ramadan Kareem for everybody. Thank you.
Thank you, Dr. Sam. I think it's time.
Yes, I want to tell good news for my colleagues. Write in the description there is in the supermarket bill to zero. So, your patient insisting to enjoy this catastrophic bill as a traditional drink. Now in the supermarket, there is one bill to zero.
So, as a question to my colleague, yes, Dr. Mahmoud Nabil, just my concern, if your patient comes and he did the surgery in the first month, would you allow him to fast in the first month after the surgery?
I put no, it's all right, my boss, it's all right. I put, which this is what I want to discuss with also my colleagues. I put in the top of my list, the hydration. Because I have seen, although it's not much patient, but it's when your patient passed and came with the hydration and symptoms of occlusion of vessels or defense or thrombosis on this thing, really I blame myself to don't tell him regarding the hydration is for me in the top of the list.
I think Dr. Mahmoud,
You find the benefits of some medications that slow gastric emptying, like metformin, that's the decrease the numbers.
you mean a medication that it reduce the motility of the stomach? In my view, only the samprostatin was mentioned. I don't have an experience with the metformin that it will really help. Your experience, my colleague, did anybody try this medication that it slow down the gastric emptying? Yeah.
The usual patient who came with dumping syndrome, they usually advise them like carbos or some metformin. We recently hear from Lynch.
Yeah, if some people they advise the PPI by itself is one of the medication that it could help in reducing the early dumping. I'm not very expert in this point actually, but we could hear from my colleague or from endocrinologist if he can advise something else.
I think we also should advise the patient to go and have IV fluid. After
But this one also will break his fasting. If he builds his IV fluid.
after breakfast.
After breakfast.
At least half day.
This is not the problem of the hydration.
Yes.
Yes, if he feels, but one day and after that to stop Allah for fine. Not every day to go for.
Feedback or حاجة يعني.
There'll be consensus, can be 60 experts, and they were talking more than 45 controversies published في مجموعة كبيرة من المسلمين معظم من India I think. كان بيتكلموا إنه 97% advise stopping fasting in the presence of persistent symptom of the 69% expert recommend delaying fasting after metabolic bariatric surgery for 6 to 12 months. And 90% felt that proton pump inhibitor should be continued in patients who start fasting less than 6 months after release. And that's the main thing. And the others, there is a consensus that fasting may help in weight loss, improvement, confirmation of any and bariatric surgery. What is the question? When should we stop doing bariatric surgery?
And let me ask you, what can you do to a patient that she fasts in the first 2 weeks post-operative?
I don't know. Now this is the question. Father, I'm not concerned about if the patient in the rest. If you give the patient advice and they do it in his own, it's responsibility. Not like in that now. I'm going to tell them non-proprietary. Okay, when should I stop doing bariatric surgery? Or do we need to stop or just want a patient that don't to fast?
Actually, that was my question to one of the scholars from Jamiat al-Imam, Muhammad bin Saud. And I was praying in one of the mosques here in Jeddah during Ramadan. And I sent him a written question, very clear. I told him I do surgery, elective, and I can postpone it after Ramadan. What is al-hukum fatwa? In doing this type of surgery during Ramadan, which enforce the patient to break his fasting. And number two, what will be the hukum of my salary in case if I stop doing these operations, okay, during month of Ramadan? I was shocked by his answer, and he said, patient is patient, مريض. واستدل على الآية إلا من كان منكم مريضا أو على سفر فعدة من أيام أخرى. يعني يجوز لك إنك أنت تسوي العملية وإنه هو يفطر ويقضي، لأنه في القرآن ما هو مذكور إنه هذا مريض سنة ولا مريض إمرجنسي ولا مريض مش عارف إيه. هذا واحد. الشيء الثاني إنه إذا سافر الإنسان وهو في طيارة وهو مرتاح وأحيانا first class, and it is given a permission for him to break his fasting. فما بالك بإنسان سوى عملية. فأنا أعتقد إنه يعني لازم نسهل الأمور. الناس اللي تيجي تسوي عملية during رمضان, this is the best time for him to do the operation. في الأيام الثانية ما يقدر. Either because he got a sick leave or his vacation or whatever. So I think we have to be flexible in these things. مو عشان أنا شغال في مستشفى حكومي أوقف عملياتي وأشتغلها في الخاص. فأعتقد
شخص واحد ممكن ناخذ اكثر من
هو سكولر من يعني محاضر في جامعة الإمام وتخصصه الفقه المقارن، يعني بيمشي على الأربعة. صحيح. أنا للأمانة بعرف وش
rephrase the question in another way. هل أي مستشفى حكومي عندنا في المملكة يسوي عمليات إلكتيف خلال شهر رمضان؟ مين أي مستشفى؟ الحرس الوطني يكمل فقط. العسكري أنت تكمله.
حتى كنت أسوي هالرحلات في اليوم واحد دكتور الأسير يقول أنت مقصود من
طيب في المدينة
بنسوي
يعني
بعض المعلومات يقول لك هو فعلا ده الوقت الوحيد اللي بالنسبه لي له فلوكيشن.
يعني you still continue.
I still يعني we still though يعني we are select اعتبروه معلومات.
احنا بالنسبة لنا مثلا مستشفى النور التخصصي في مكة المكرمة we stop all the elective. But maybe there is another reason from our side, يعني especially regarding Mecca, because of it will be the higher season for Ramadan, and we know how heavy will be the emergency cases in Ramadan. But this is the other reason why we are with all the elective cases in North Cyprus Hospital. But for other governmental hospitals, the Malik Fahad is still instead. So instead you continue. لا, we are talking about Batayyah. يعني what other elective cases?
خلينا نخش again. اللي أقصد إنه at the end we still in the practice. We still doing patients. خلاص in Ramadan. في الأخير if we want the patient إنه you cannot fast وتقول له استكفي في أمرك, فهذا أدنى الأشياء. لكن أقصد إنه إحنا when we should advise the patient to fast يعني safe. يعني الآن أنا لو جاني مريض في رجب أو في جمال أقول له إنه ما حتقدر تصوم رمضان؟
Yes.
This is the question.
Prior to that.
بعد هل في consensus؟ فالسؤال هنا يعني do how يعني what's the period that we need to really obligatory إن إحنا we don't ask the patient يعني متى I start to warn the patient فالأخير هو مسألة الحرمانية ومسألة الشرعية ما نقدر نفتي فيها، وأعتقد كان واحد من النقاط اللي ناقشها الدكتور محمد الجاني قال لو تستدعوا شيخ، لكن أعتقد إنه يعني هذا ممكن السؤال هذا يطلع عن طريق رئاسة الجمعية، لكن هو السؤال الآن إحنا لازم نوصل للكونسنسس إحنا أطباء عشان لما نحط سؤال شرعي نقدم سؤال شرعي نقول للشيخ والله المريض لا يستطيع أن يصوم إلا بعد 3 شهور. هنا حتختلف الامور لانه في ناس ما تقدر تستنى، ما هو معناته انه اوبيستي انها يعني يو كان بوستبون ويتنج ليست مثلا في المستشفيات الحكوميه. زي انا لما كنت شغال في مدينه الملك عبد الله I was obligated by the waiting list was يعني 1 year or 1.5 year I had to do patient في رمضان عشان to defeat the waiting list. فالان هو الفكره انه عشان تجيب حكم شرعي او سؤال هل احنا اتفقنا على بيريود محدده انه to tell the patient this is the only period you need to stop يعني don't fast. هذا اللي هو السؤال. فناس بيقول له انا بيجي المرض بيقول والله الدكتور حقي قال لي بعد اسبوعين. في ناس بيقول له والله شهر، في ناس بيقول لي 3 شهور. الان الكونسنسس قال لك 6 to 12 months. فاحنا يعني الموضوع صار متعوق يعني. فما في كلير ايفيدنس عشان انا اقدر اسال شيخ اقول له وش حكمه، لانه لو 6 شهور طبعا اوف كورس يعني في ناس ما المرض انا اقول مريض از مريض تمام، لكن لو شهر هل حتفرق شرعيا ولا لا؟
Let me ask you something. I mean, you could say the same thing on non-pediatric cases. For example, you will stop doing the lab queries 1 month before the Ramadan, just in case this patient if he develop any side effects or complication from the surgery. So he will be in the safe side. Of course, he will not do it. Number 2, for the pediatric patients, if they did not do the operation, percentage of them they used to do, which is the fasting diet. وإيش اسمه اللي هو صيام yes, an intermittent fasting, and they can fast up to 16 hours. So doing the operation, and he continue fasting, and he start fasting after 1 month after finishing the liquid and salt. You will tell him, no, don't do that. Of course, before you do the operation, he said, listen, it is better to finish the liquid and the salt diet when you start the solid, then go and start fasting. And of course, you have to modify the kind of diets and frequency and these things, and you give him the same instruction he mentioned to Sam after breaking the fasting. So I don't think we have to tell the patient, no, you cannot fast for 3 months after the operation. Give him the chance to fast and tell him, if you really get tired from fasting, then break your fasting. It is permitted by that.
Can I ask you a question? Like, why do we really know? It's okay. Why do we stick to solid food? Why not? Since we have already formulas that he can use before that to achieve his nutritional target. Why did we advise really for يعني مختصر? Like, why do we have to reach to a certain stage if the patient if we can reach to enough hydration, enough nutritional supplements, then we can start right away.
Good question. Look at the patient after the surgery when they are at the period of liquid diet. They are not energetic. Okay, they lose energy because all of a sudden their calories intake is dropped from 4,000 to like 700-800 by the liquids.
600 for 2 months. Straight 2 months, they can't exceed 700. Exactly, as you said, for a straight 2 months, they cannot exceed 700.
I usually keep them for 2 weeks on liquids, then a soft diet.
And even during the solid food period, in the first 2 months, none of them can really reach more than 700 at most.
But if you look at their level of energy after 1 month from finishing the liquid and the salt, they are really back to their normal energy.
Because of the metabolism, right?
Because of the metabolism, part of it may be psychologically,
Exactly.
and back to normal. So I think they are very happy at that time to fast. And at the same time, as I mentioned earlier, you can tell them, instruct them, if they get tired from fasting, you can break with fasting, okay? And try it after a couple of days, okay? Maybe you will, and you can do like intermittent fasting. If you get tired after 8 hours, break your fasting. Next time, make it 10 hours, and so on.
So I think, just to summarize what you said, if we have a certain nutritional goals that we can set for the patient, then he can fast at any time, right?
طيب الحقيقة نحن we got the extension من المطعم إلى 11 ونص so we need to move. like أول شيء يعني جملة مثل الدكتور حسين صباح الدكتور فهد الجريسي for attending coming دكتور حمود دكتور عبد الله will conclude the session. It's really hot topics a lot of controversy يعني كل المواضيع اللي جبناها اليوم ما عليها consensus حقيقة but it is good to discuss it good to يعني إنه إحنا نبدأ نبحث في الموضوع هذا. أنا أعطيكم تجربة شخصية عشان بس أقفل الموضوع. أنا كنت أخلي المرضى يصوموا بعد أسبوعين بعد الفيلم لما يبدو الصبح. In the last year, I have 2 patients with portal vein infections during the month. After that, I extended my period minimum 1 month. Sometimes I give them شهر ونص. حقيقة. But it's really to look at our experience. يعني ننظر إلى our experience ونشوف نقدم honest data. لو كل المستشفيات نقدم honest data. ليه لو قدمنا معلومة زي كذا إحنا نعرف بعد كذا إحنا المسلمين إحنا المفروض publish اللي هو البيست بارتنر تايم. اذا مو من عندنا احنا الغرب يعني نتكلم وما يعرفوا النظام السياسي. تفضل
شكرا جزيلا for all of you organizing committee for these nice topics. We learn a lot and share all with you all, and I hope after Ramadan inshallah we'll have the next number 4 this and we hope to see you وكل عام وانتم بخير والله يحفظكم جميعا.